So our next speaker is Dr. Alkharashi, Majied. He will be talking about smoothing the bumpy cornea. So Dr. Alkharashi is an associate professor of ophthalmology at King Saud University. And he completed his residency at McGill, did his cornea fellowship at the world-renowned Wilmer Eye Institute at Johns Hopkins. He's currently an associate professor at King Saud University in Riyadh. Without further ado.
Well, thank you so much for the kind invitation. And
you need this
it's
one.
really my pleasure to participate in Adore. First, I would like to invite you all for our workshop tomorrow, me and Dr. Amna on treatment of irregular cornea. So it will be a continuation of my talk today, and we will discuss the technical aspect in treating abnormal corneal surface. I know my talk is the end of the session, and you are dying to have your coffee, so I promise you it will be fun and enjoyable. It will be a case-based presentation where I'm going to show you some of my cases. First, why do we care about having abnormal corneal surface? What's the problem of having abnormal corneal surface? You know, the function of the cornea is to refract the light rays in a perfect manner. Number two is to be clear, so the light rays will pass through the cornea. So if you have an abnormal corneal surface, you might have blurry vision that cannot be corrected with glasses nor contact lens. Cataract surgery become more of a refractive procedure, so it's not just removing an opaque lens anymore. The patient demand a lot from you. They want to be glasses independent at distance and at near. They want to see perfectly in all conditions, even while sleeping. So having an abnormal corneal surface might limit the outcome of cataract surgery. And lastly, it might cause some discomfort, like patient with keratoconus and apical scarring, wearing hard contact lens. The apical scar might cause some discomfort. So how to treat abnormal corneal surface? Well, abnormal corneal surface could be a simple SP case because of a dryness that can be corrected and treated easily with just lubricant drops. Sometimes the abnormal corneal surface could be an opacity in the cornea, and this can be corrected with or treated with a cheap blade that will cost $10 or a fancy machine that will cost $1 million. And removing this opacity could be just peeling off this opacity from the cornea if you find a plane between the opacity and the cornea itself. And sometimes you have to cut it off or ablate it off the cornea if it is within the corneal tissue. And we'll go in details with this in the workshop. So this is the first case. This is a 38 years old nice lady who had meningioma resected 2 years ago. And Dr. Mahmoud, our colleague, the neurosurgeon, was kind enough to call me about this case, but 2 years after the procedure. So she developed the exposure keratopathy, and she had a chronic neurotrophic ulcer. Someone tried to counsel her for doing corneal transplant, but you all know doing corneal transplant in a 5th and a 7th, it's not a wise thing to do before addressing the abnormal corneal sensation issue. If you look at the OCT, the anterior segment OCT, you will see that there is significant scarring just under the epithelium, as well as there is some scarring within the corneal tissue. So after long discussion with the patient, she agreed to have superficial keratectomy with amniotic membrane and total tarsorrhaphy. And this is what we did. So we were able to find the plane between the scar tissue and the cornea, and you can just peel it off easily. Of course, there is some scarring underneath. However, her vision improved. This is her picture, clinical photo picture 1 week after the procedure, or sorry, 2 weeks after the procedure. And you can see the improvement before and after, and her vision improved to 20/80, and she's extremely happy. Having an abnormal corneal surface in a patient coming in for cataract surgery might cause a lot of issues. First, you'll be surprised how common dry eye in a patient coming in for cataract evaluation. Gupta and others found around 80% of patients who came in just for cataract evaluation has some sort of dry eye disease. So what's the issue of having an abnormal abnormal corneal surface in a patient coming in with cataract surgery? First, the patient might not be happy after the cataract procedure. Why? Because still the patient is not seeing very well, still has the same problem that he came in with, and we don't want to see unhappy patient in our clinic. So if you don't want to see unhappy patient, look at the cornea very carefully. Two, we use the cornea to determine the intraocular lens power. So if you have an abnormal corneal surface, your calculation might not be correct, and you might have wrong calculation and wrong IOL implant in the patient eye. And even if you ask the patient to pay extra for the premium IOL and the patient has abnormal corneal surface, he might have problem like glare and halos because of the abnormal corneal surface. One of the common bumps that we see in our region is pterygium. This is a common case. Patient came in for cataract surgery and he has a nasal pterygium that's causing around 6 diopters of corneal astigmatism. If you look at the IOL calculation, the suggested intraocular lens to be implanted in this patient is around 20 diopter. If you look at the same case, it's around 39 diopter. So if you do a cataract surgery with pterygium excision at the same time, what do you think will happen to the postoperative refraction? The resident in the room, what do you think is going to happen? So if you have a flat cornea, you have to compensate for this flattening in the intraocular lens calculation. So the intraocular lens power will be high, and the patient will have myopic surprise after the procedure. So this is the patient underwent pterygium excision with amniotic membrane, and you can see that the corneal curvature improved and the average K become 44. So the suggested power while the pterygium was still in the cornea is around 20 diopters. However, when you remove the pterygium, it's 13.5. This is another example, but this is a professor in the university who came in complaining of blurry vision, and someone told him that he need a cataract surgery. If you look at the cornea very carefully, you will see that there is a clear epithelial basement membrane dystrophy involving the visual axis. And this is his corneal curvature. There is some asymmetry, but it's not that significant. And this is his IOL calculation and the anterior sigmoid-OCT. You see that the most of the opacity is just under the epithelium. And if you look at the epithelial map, it's quite irregular, and it is in the visual axis. So after counseling, doing superficial keratectomy for the patient, he agreed. And we did only epithelial debridement. We did nothing fancy, no excimer laser, no turbo-guided, nothing, just epithelial debridement. And he was extremely happy. And even he did not do the cataract surgery because the quality of the vision is improved. I'm running out of time. However, I would like again to invite you for our session where we'll continue with same cases. So I think I will stop here.